I feel sometimes like I'm complaining when I'm talking about the psychological effects of treatment, and I don't, of course, mean to do that, like complaining to oncologists that, gee, I got your patient in remission, now you're telling me there's more problems. But it really, that was a great introduction to talk about why some of our patients may have persisting anxiety and depression after treatment. To give you a bit of a context for where I'm coming from, I'm a psychologist, trained as a geropsychologist, and I've been at the VA for about 20 years. I do individual, family, group psychotherapy for veterans referred from medical professionals for anxiety and depression in the context of their medical illness. And my research in the past has been on decision-making capacity, because I'm so interested in the experience of illness and how it impacts how people make decisions. But more recently, I've turned my attention to cancer survivorship. So I'm so pleased to tell you about that. On this slide is a picture of Orpheus. And I'm going to be using some, the story of Orpheus and some paintings from that story to try to bring us into the affective experience of patients, because I'll also be throwing a lot of numbers. I'm so delighted Greg's up here, so you can also keep us focused on the patient's experience. I need to let you know I have no financial conflicts of interest, but I do want to thank the veterans who participated in our study, our Vet Cares research team, the special interest group on cancer survivorship, and funding from the Department of Veterans Affairs, Rehabilitation, Research, and Development. I'll be talking about these 4 issues: cancer-related PTSD, worry, depression, meaning-making, and a couple of slides at the end on clinical implications. Our survivorship study, let me tell you a little bit about the design. We identified patients through the tumor registry at Boston and Houston. We used CPRS to screen out patients who had dementing or psychotic disorders that would interfere with their ability to do the interview, and also looked at the oncology progress notes and excluded patients who were referred to palliative care. That is, we're trying to identify survivors for this study. Of the 416 who were eligible, we had 170 agree to be interviewed. We did in-depth face-to-face interviews lasting about 2 hours, and that allowed us to do a really careful symptom assessment as well as get some good qualitative data. And then we did follow-up interviews at 12 and 18 months post-diagnosis. The table at the bottom shows you that 72% completed all 3 interviews. We had 10% who died and about 20% who declined to do our subsequent interviews. So that's actually a good rate of continuation. I think that says a lot about veterans. Once they commit to something, they follow through. We had a wide age range, but most of the veterans were in that group of maybe 55 to 75 with a mean age of 65, mostly male. We studied these 3 cancer types: head and neck, gastroesophageal, and colorectal. We did that because this was an interview study, and to get the sample size we needed to look at a group of cancers. So we selected this group of highly prevalent cancers within the VA population that had some common sequelae in nutrition and digestion. We had a good distribution across stages of cancer, and you can see about 1/3 had surgery only, and the rest had surgery plus additional treatment. Let me say a word or 2 about how I'm defining cancer survivorship. I'm using that broad definition like NCI, post-diagnosis, not in palliative care. Now, some of you may be thinking, boy, this is kind of goofy to be looking at a study combining across types and stages and treatments, and it is not ideal. But interestingly enough, in these outcomes I'm talking about today, these variables, these cancer variables, were not so predictive of PTSD, worry, and depression. What does come up over and over is younger age and current combat PTSD. So I'm talking about the evolving psychological experience of cancer. And I want to run you through this pretty simple survivorship model that informs our work to orient you to the table. On the left column are these variables, and the rows going across relate to each of those variables. So across the top is time, initial treatment through remission and continued remission or relapse. I want you to be thinking about your contact with the patients during that initial treatment phase, frequent, intense contact with you, and then moving into the surveillance phase, patients lose that frequent, intense contact and hopefully reconnect with primary care. In addition to treating the cancer, you're focusing on managing those acute side effects of treatment. And for patients, I think in that initial phase, there's that sense of relief from those acute side effects, but it's beautifully presented to us moving over time, the awareness that, oh, some of these symptoms are with me. These are long-term side effects or late emerging side effects. Psychologically, what we're proposing is for many people in that initial treatment phase, they're sort of in combat mode. They're focused on, in a crisis way, on getting through that treatment. It's after treatment ends that people begin to have maybe the psychological space to do that processing and meaning making and thinking about, wow, what just happened to me? What does that mean for me? And we're proposing that there's different trajectories, and I'll say more about that later. So let's start with trauma. Now, I know you can't see a lot of the details of this painting. This is a 16th century painting of Orpheus in the underworld. So in the story of Orpheus, his wife dies and is taken to the underworld, and he is given the chance to go down there and retrieve her. What I love about this painting is it conveys how scary of a place this is to visit, that's dark and foreboding, and there's lots of frightening pieces. And this is why I think for some people, cancer is a trauma, the diagnosis, but also the treatments. In DSM-5, that's the most recently released nomenclature, PTSD has these 4 elements on the left side of this table. Re-experiencing, so that's I'm having dreams about my diagnosis and treatment. I find myself thinking about it when I don't want to. Avoidance, trying to stay away from things that remind me of cancer. The negative cognitions and mood component is more than depression. I think one of the key words there is estrangement. It's the sense of this cancer has separated me from others. I feel isolated or alone or different. And then the arousal symptoms. So how is cancer potentially like trauma? Well, on the right is the DSM diagnosis there, exposure to something that involves actual or threatened death, serious injury, or sexual violation. So you can see that it would seem like cancer might fit that category. And I think also we have, with the treatment and needing to come back, it's sort of like, we're going to bring you back to Vietnam, and we're going to bring you back to Vietnam, and we're going to bring you back to Vietnam. And so you can see why that might accelerate the experience of trauma for people. We're going to bring you back to oncology clinic. We're going to bring you back to the oncology clinic. There are important ways I think we need to recognize that it doesn't fit, that it's not like trauma. I think the most important thing in my mind is all of this is occurring in a context not of people trying to harm you, but of people trying to help you. And for this reason, I think the appraisal of whether or not cancer is trauma is quite variable. We asked these questions that are from DSM, and you can see, look, a third or more of the people said, no, I didn't think I was going to die. I didn't think I was going to be injured. But about 2/3 answer yes to at least one of those symptoms. So that means technically they are answering that cancer was a traumatic stressor for them. But what about PTSD? So we did an assessment of the 17 symptoms of PTSD, and 1 in 2 people endorsed at least one symptom. Yes, I have been having nightmares, but if needing to meet all of those pieces of PTSD, only 1 in 10. And here's our longitudinal prevalence, and this is where, again, mirroring our previous talk, I start to feel concerned because we see maybe a little bit of a dip initially, but continuing around at 18 months, that 1 in 10. So who are these 1 in 10? As I mentioned before, people who are younger and who have current combat PTSD report higher rates of cancer-related PTSD. Another way of saying this as a geropsychologist is, of course, there's variability across person, but as a group, I think older adults may be more resilient psychologically when confronted by cancer. It's like, oh, yes, 10 years ago I had a heart attack, and 5 years ago my wife died, and now you're telling me I have cancer. They build up resilience in dealing with difficult life events. There is this complex interrelationship between cancer and combat PTSD, though, right? Because some of the symptoms we can differentiate. Are your nightmares of cancer, or are they combat? But some you really can't. Is your estrangement from cancer or from combat? So we look, trying to dissociate these two, we looked at how do they predict quality of life as a more distal outcome. And both combat PTSD and cancer PTSD, and we controlled for that collinearity or that relationship, are predicting patients' reports of their social quality of life. And cancer PTSD, though, is the one that is associated with patients' reports of their physical quality of life. And here is that goofy finding where cancer type, stage, and treatments are not predicting patients' reports of their physical quality of life as much as cancer-related PTSD. What about combat itself? So if combat PTSD is a risk factor, what about whether or not people have experienced combat? And the answer is it really varies across people. For some people it's a risk factor, for some people it's a resilience factor. We asked, during your cancer treatment, were you reminded of your combat? Yes, in combat there is nowhere to go but to report to duty. In cancer, there is no escape, nothing to do. So you can see the psychological similarity there. But we also asked, did getting through combat help you cope with cancer? And here we also see the resilience. Vietnam made me unaffected by bad things that happen. Or Vietnam helped me grow up and accept responsibility. Now I face life head on with a better understanding that my situation could have been worse. I want to tell you a little bit about the support group that we offer in our outpatient mental health clinic. I sheepishly share with you this is a little model I did in an art class I took, and I confess in front of me was this beautiful female model, but I had come out of the support group that day and I started doing something a little bit different, and this is meant to be our support group. We had a patient with esophageal cancer that had been removed, lung cancer, and bladder cancer. And what I think is conveyed in this, I hope, in this model, is the effect that the support group has on that cancer-related PTSD symptom of estrangement. I think now there's a sense of belongingness. What is also fabulous about this group is a lot of help with managing these practical symptoms, I may say this, practical approaches to dealing with the symptoms or things that they need to do. Like they share different ways that they have used to get themselves through their surveillance scans. You know, whether it be their own little drug cocktail, if I do Benadryl plus Ativan, or other sort of more psychological ways that they approach that. So in some ways it's a positive group because there's an emphasis on managing side effects and surveillance. Let's move on now to talk about worry. This is, I think, just an amazing painting by a 20th century artist, Elsie Russell. And in the story of Orpheus, he is allowed to go into the underworld to get his wife, but there's one rule, which is he can't look at her until he is out. And unfortunately, he's unable to resist and looks at her. But why I like this painting when we're talking about worry is because for me it's such a scary representation of what it is to be looking at the thing you love and may be losing. And that is how I think worry is different from PTSD, where, there it is. With PTSD, we are speaking about something that has happened to you that's difficult and traumatic and is affecting you now. With worry, we're focused more on the other side of this IOM cancer survivorship diagram of what may happen. We are very interested in the concept of worry and did a lot of work to try to flesh out what is this construct. So we did individual interviews, then we did focus groups, and we asked people, what are you worrying about? And we wrote it all down and developed all these items and then reduced that to a smaller number of items and gave those to this sample of 170, and then used item analyses to further try to figure out what are the major domains of worry. And the first one, which is often talked about in the literature, is fear of recurrence. I'm afraid of scans. I'm afraid because they may indicate my cancer is coming back. Other domains of worry, healthcare. I'm going to tell you some of the items in this. I'm worried about, do I have the best care? I'm worried about, it was interesting, this item loads onto the healthcare. I'm worried about if I die, will I have dignity as I'm dying? I'm worried about being a burden on my family. This existential category is things like, I'm worried about, am I making the most of every day? Am I doing everything I need to be doing to beat it? And the recovery domain is more like, I'm worried, why am I having these symptoms that aren't going away? How can I feel better? When can I return to work? This is the longitudinal snapshot of these worry domains. And one thing that I want to point out to you is the healthcare worry is actually very minimal. So by and large, our veterans are not expressing, they're expressing confidence and appreciation in their healthcare. You know, some have some worries, but that's the small group. There's a little bit perhaps decrease in fear of recurrence over time, but not much. The decrease in worries about family, that is statistically significant, but the existential worries, the recovery worries, they're staying at the same rate over time. Why is worry important? When you look at some of these broad somatic symptoms, so fatigue is one of our most common complaints in cancer survivorship. Look at that correlation with worry. Now that's not to say, oh, the fatigue's all in your head. You know, fatigue is multifactorial, but worry is correlated with it. Of course, it couldn't go the other direction. I'm so tired, I'm worried. But my thought as a psychologist is if I can do anything to help with the worry, could that decrease the fatigue or allow us to use other approaches, exercise, whatever, to address the other aspects of fatigue? Oh, I wanted to tell you about a study we did using yoga, and our approach here was to see if we could make a difference on both that worry and anxiety and the fatigue. So there's a handful of studies looking at yoga as an intervention after treatment for breast cancer in middle-aged women. And so my question was, well, that's really cool. Will our old veterans do that? And we were able to recruit. We did not only will they do it, but once they do it, what do we have to think about in terms of the multiple comorbidities they may have? So we had a physical therapist do pre-assessments to look at balance, and then also in this picture, range of motion. So seated is our yoga therapist, standing is the physical therapist, and they looked at every pose, every transfer to see how it had to be adapted. Here's a picture from the group, and what you'll see is that all of the poses can be done from a chair, but we also provided mats and bolsters. So if people wanted to and could go to the floor but needed supports, we had that for them as well. We're just starting to look at the results of those studies, but I can tell you qualitatively that the veterans really liked both the stretching, strengthening, but also the relaxation training. That is a big part of yoga therapy. Okay, let's move on to talk about depression. In this painting by Waterhouse, poor Orpheus, after the whole incident with his wife, he dies and gets torn to shreds, and his body parts go floating down the river and are seen by these nymphs. And so there they are looking at the pieces of Orpheus and his life in grief. And I chose that for depression because when you start to add up the number of losses that face people with cancer and its treatment, it's really astounding. There's sort of this obesity of loss. When we look at rates of depression, this is at 6 months. You know, the good news in all these slides is many people are doing well. The bad news is that there's a portion who is not. And so 25% reporting major depressive disorder, 1 in 4 major depressive disorder. We looked at, or those people who had had depression before, and it's sort of evenly split. About half of them are people who had had depression, major depression in the past, and now have a recurrence. The other half, no history of depression, a new onset, a new incidence of depression at 6 months post-diagnosis. And here again, not really showing much change over time. I'll share with you the story of a person I treated with psychotherapy. We also treated him with medications. I always like to share cases that didn't go perfectly. We can treat major depression, and a lot of times we are able to treat it. This person, I felt like we were only able to treat it partially. He came to us really with all the things that we just heard about at 18 months post-treatment with depression and suicidal ideation. And I felt that I was moderately successful. We worked on acceptance and thinking about how he might approach his life going forward, the sexual changes, the sexual desirability he was feeling, and how we might impact that. But really, one of the things that I felt was the sticking point were these physical symptoms. And I felt like, gee, he'd be less depressed, I think, if he could have more mouth movement. And our speech and language therapist was working with the Dynasplint with him, and I think that he wasn't very compliant with treatment. So I think that speech and language therapist was probably thinking, I can make a lot more progress if he wasn't so depressed and discouraged and hopeless. So that's just a reminder about the importance of integrated care, and we're making progress on that in the VA, but I'm still not sure we're there in terms of our cancer survivors. In the remaining portion of my talk, I want to talk about this idea of meaning making, which is the word I prefer to cognitions and cognitive therapy, but it has a lot in common with that. When scholars look at how do people make sense of difficult or traumatic experience, they talk about these 3 domains that people might need to grapple with. The meaning of the event. Why did I get cancer? The meaning of the self. What does it say for who I am, how I think about who I am, and the world? Is the world fair? Is it just? What does it say about how I think about larger issues like God or spirituality? There are lots of reports of the difficult PTSD, worry, depression that I've described, but also of positive meaning making following cancer treatment. And these are the 5 domains that come up over and over in those studies. So one of the domains is relationships. This experience has been really hard, but it has brought me closer to my spouse. I'm feeling very worried, but you know, I've always wanted to learn to ride a motorcycle, and now I'm doing that. Personal strength is, I realize that I'm stronger than I thought. Spiritual change, I'm feeling closer to God, and appreciation of life, a big one. You know, this is the most important thing for, I think, almost any of us, right? I've really learned to appreciate each day. Now, not everyone has these positive. Some people may be on the negative side, like the cancer has pulled me further from my sense of closeness to God. But regardless of which way it goes, to me, this is all fodder for psychotherapy. How are you making sense of this? Why? Can we talk about that? Can we work through that? Are there different ways to make sense of this experience? Rilke wrote these sonnets to Orpheus, and he did them on the wake of the death of someone he was close to in this intense period of productivity. About 4 years later, Rilke himself dies of leukemia. But a lot of these sonnets deal with how people make meaning of difficult experience. They're just beautiful. Here's an excerpt from one. Let this darkness be a bell tower, and you the bell. As you ring, what batters you becomes your strength. Amid the rafters of dark belfries, let yourself peal. And let's give you some examples from our veterans. I have a sense of my own mortality. I'm not as self-focused as I used to be. It's opened my eyes. I tend to take things a little more slowly. Life's too short. Or I don't want to die. That's an established fact, yet it doesn't hold the tiller like it used to. I'm still afraid, but not to the degree I was before. So as you can see, fodder for psychotherapy, a lot of positive and negative ways that people are trying to make sense of this experience. So in summary, our data is showing cancer survivorship as an evolving psychological experience, PTSD, worry, depression, a problem for some, but not all. But when it's there, it's looking like we're not getting at it. It's persisting over time. And just like the beautiful box plots in our previous study, the mean and correlational approach really misses the trajectories. And that's what we're working on next as we look at our data. There do seem to be people for whom this is kind of a minor bump and they move on. These are some of the 85-year-old veterans who said, yeah, I jumped into Normandy, but I didn't let it bother me, right? Some people, that's how they deal with difficult experience, they move on. Others, there is this struggling, this pausing, this thinking about what it means, regrouping and moving forward. And there seems to be a third group who is really getting stuck. So what I want to do as we continue to look at these data, see what we can do to further identify who most needs our attention psychologically so we can get those referrals. 2 slides on clinical implications. One of our oncologists, who's wonderful, she's wonderful, but she was concerned about, don't give me another checklist, please. Those of you who do clinical reminders know where I'm coming from. So what can we do to help our patients collaborate more with us, to help them be more willing to bring these concerns forward? And so that brought the question for us about why aren't these concerns being brought forward? And we asked the veterans in our study, do you ever not tell your doctor or avoid or miss an appointment? And if so, why? And almost half said, yes, I don't share that I'm feeling tired and I'm not sleeping because I am just tired of it all. I'm tired of coming to the hospital. I'm tired of seeing you even though you're very nice. I'm just tired of it. And the next biggest thing, about 25% of our sample said, yeah, I don't share that I'm feeling, again, having trouble sleeping or feeling so drained because I'm afraid. I'm afraid that you're going to tell me the cancer is back. So I just keep these things to myself. The good news about this slide is what's down at the bottom. They feel, it's not that they're embarrassed or they don't know where to go to or they're not confident in us. It's these psychological factors that may be needing some coaching. Our Cancer Survivor Special Interest Group has developed this wellness plan that's based on the data I presented to you today, trying to pick some of the most common concerns. It does look like a checklist, so I hope, though, it's a helpful checklist. And our thought is maybe when patients get that treatment summary and their surveillance plan, that they might also get this wellness checklist that says, and this is some of Ellen Ballard's words, you've had treatment for cancer, don't neglect the rest of you. It's normal to need some time and some help to recover. And so hopefully we might ask them, are you having these problems? And if so, let me refer you. But it may be they're having the problems and they want a little break. They're tired of it all, but that means we can't just forget it altogether. So I think also a coaching piece. As you're recovering, when you next go to visit your primary care doctor, maybe you want to tell them about some of these concerns you're having. Again, we're trying to prevent this lost in transition and find a way for these problems that are persisting to come forward. And with that, now see, I left 36 seconds, not as good as you. We have this, I'm on my yellow light, but not to the red. So we'll move on for our last talk. Thank you.